I'm back once again with the topic on temporary anchorage devices in orthodontics, part 4. For those who have missed part 1, part 2 and part 3, I would request them to kindly look into the link and then get yourselves acquainted, because that would help you in having a better understanding of the complete topic on temporary anchorage devices in orthodontics. So in part 3, we deal with the extra alveolar screws, and I had mentioned about the IZC as also the MBS screws. In part 4, I would just like to show a case report wherein we have used an IZC screw. So this was a patient who had reported to us in his growth period, and he was a skeletal class 2 malocclusion with a prognathic maxilla and a retrognathic mandible with a low mandibular plane angle and with a convex profile. And he had a severe overjet of about 12 millimeters, and then we were wondering, should we remove the first premolars and retract, or can we achieve entire maxillary distalization with the use of IZC? So we then struck on that idea and we said, okay, let us do it in this particular patient, wherein we shall do complete maxillary arch distalization without the extraction of the first premolars. So he was skeletal class 2 as also Angus class 2 division 1 malocclusion with almost class 2 molar relation on the right and the left sides, as also class 2 canine on to the left and the right side. And he had the 4-2 which was lingually placed, but we did not remove any teeth in the mandibular dental arch 2. So we strapped him up with the MBT technique, 022 into 028 slot, and then we used an IZC bone screw which was roughly about, I presume, 14 millimeters in length and 2 millimeters in diameter in the IZC 7 region, and we started the retraction of the teeth after initial leveling and aligning the teeth, and then the maxillary incisors were tipped back, and then the whole arch was distalized. And then this was what we observed after the completion of treatment, and you can see that he's got a good consonant smile arc, and then you can see his facial profile has improved dramatically. And then this is the little OPG depiction of where we had placed the IZC7 screw, and you can see the left side is the pre and the right is the post, and we have achieved class 1 molar relation and class 1 canine relationship, both right and the left sides, and the arch has been well aligned, and you can see no extractions have been done in this case. And similarly, you can see the left side the pre and the right being the post, no extraction was done, and all the teeth have beautifully aligned. And if you see the lateral cephalometric radiograph, an overjet of about 12 millimeters was effectively treated to an end result of about just about 3 millimeters, which is almost normal overjet, and then we also had a normal overbite. And this was the wondrous action of the IZC, which was used in this particular patient without extractions of first premolars. So this particular case had been published under the title Correction of Class 2 Skeletal Malocclusion with an Infrazygomatic Crest-Bone Screw Approach in the Indian Journal of the Public Health Research and Development and International Journal in the year 2019, and those who are interested could also look into it for the other details of the case report. So what are the limits of distalization? We say we can take the teeth back. What could be those factors which we need to take into consideration? So far as the maxilla is concerned, of course, this is age dependent. We have got the third molars. If the third molars have been erupted, kindly do extract it. If they are not erupted and you can just see the crown, etc., which is below the cement or enamel junction of the adjacent maxillary second molar, yes, you can attempt distalization. And of course, we do the cephalometric analysis. The sagittal distance from pterygoid vertical would also give you more information whether you can distalize or not. Same thing holds true for the mandible. third molars. If present, kindly do remove. And if it is placed a little bit below the cemental junction of the mandibular second molar, then you can sort of attempt. But then we have something known as the lingual cortical plate. As you can see in this particular figure, the lingual cortical plate is present there, and when the teeth are being distalized, when they come and strike this, something known as the angle of inflection, which is present down there, hinders the distalization of the mandibular molars. So then if you see such a situation, you cannot distalize the mandibular molars more. So you need to have a good idea as to have enough bone left distal to the mandibular second molar for you to bring about effective mandibular distalization. We have dealt with microimplants which are placed in between the roots of the teeth. We have dealt with extraalveolar implants like the IZC and the MBS. But there are also certain other skeletal anchorage systems which are the I plate and the Y plate, but these require major invasive surgical procedure in contrast to the others where you require minimal invasive surgical procedure. So these are done more so by the oral and maxillofacial surgeons, the placement of it, and then we continue with orthodontic work. So the use of mini plates for complete distalization of maxilla, if it is so used, the authors have found a molar distalization at around 3.78 millimeters in the region of the crowns and 3.2 millimeters in the region of roots, and concluded that the use of a skeletal anchorage system combined with mini plates is recommended for class 2 correction by means of maxillary distalization. So whatever said and done, the distalization that you could achieve would be around 2 to 3 millimeters maximum for the maxilla. So when you have a transverse maxillary deficiency, you have a collapsed maxillary arch, then you can also use the MARPE, which is the mini implant assisted rapid palatal expansion, where you can see you do have the rapid palatal expansion in the palate, and then you have the 4 helical holes where you can place the implants. This is anchored to the bone, and then the arms are being soldered to the maxillary first molars, and then when you start to open up the mid palatal suture, you get an effective correction of your constricted maxillary arch. So you can have different designs, and according to the different designs you can do this particular treatment for the constricted maxillary arches. And you can see how well the mid palatal suture opens, and by this even your nasal breathing improves and the collapsed maxillary arch is effectively widened or expanded. So what are the biomechanical principles that we need to know as orthodontists? First and foremost, force. Second, moment. What do you mean by moment? We all know that. Force acting at a distance. We need to know the center of resistance, not only of the teeth but also the maxilla and the mandible, the full dentition, the full arch, as also the center of rotation. Because only when we know all this would we be able to position the microimplants properly and achieve what we want to achieve. We all know mini implants have a force vector which is more vertical in nature, but the negative side effect would be posterior open bite and anterior deep bite. But the bone screws have a force vector which is parallel and close to the occlusal plane. This reduces the chances of occlusal plane rotation. The negative side effect is a rolling in of molar, which you should compensate with an expanded arch form or torque in the arch wire. So if you want to retract the anteriors en masse, where should you place the microimplants? Because the placement of your microimplants in relation to the main arch wire and what you want to achieve with its placement, either low, medium or high, differs from case to case. So microimplants placed at different heights on gingiva relative to the occlusal plane create several biomechanical orientations. We call it a low placement when it is less than 8 millimeters for the maxilla. We call it low placement when it is 6 millimeter for the mandible from the main arch wire. That is what you see, the blue band. When you see the red band, it is medium placement, 8 to 10 millimeters for the maxilla, 6 to 8 millimeters for the mandible from the main arch wire. Medium pull sliding mechanics. So when you're going to place your microimplant, as I just mentioned to you, in the medium category, your maxillary occlusal plane is maintained because you have a clockwise movement created in the anterior region, and then you have an anti-clockwise movement created in the molar region, and thus your maxillary occlusal plane is maintained. Ideal in those cases, you want to maintain it, and you do not have an anterior open bite or a deep bite. So this is where you place it, medium placement. When it comes to low pull, here the maxillary occlusal plane is going to rotate in a clockwise direction. You can see the moments created anteriorly and in the posterior region. It is clockwise. This is very useful in those cases where you have an anterior open bite, because if the maxillary anteriors were to rotate clockwise, your open bite will close. So you see, where you're placing matters a lot for the different types of malocclusions. So far as the high pull maxillary occlusal plane is concerned, the maxillary occlusal plane will rotate in a counterclockwise direction. So if you have a deep bite, an anterior deep bite, the maxillary occlusal plane rotating in a counterclockwise direction is favorable for you to correct the anterior deep bite. Same thing holds true for the mandibular occlusal plane. Now if you are going to place a microimplant in the medium height category, the mandibular occlusal plane is maintained. There is no rotation of the mandibular occlusal plane. But on the other hand, if you are going to place it low, the mandibular occlusal plane rotates in a counterclockwise direction. Also very useful in the correction of an anterior open bite. And on the other hand, if it is placed high, the mandibular occlusal plane rotates in a clockwise direction. So if the anterior rotate in a clockwise direction, your deep bite gets corrected. So you see how important it is to know where to place these microimplants, either medium or low or high, for the different scenarios, for you to maintain the occlusal plane, for you to correct the anterior open bite, and for you to correct the anterior deep bite. So the biomechanical principles are very important in the placement of the microimplant and the usage of your crimpable hook in the anterior region. More closer towards the center of resistance, a translatory movement takes place. But can you place it so high? No, we cannot, because it's going to hurt the vestibular area. So we need to be a little bit careful. If you want to retract and intrude the maxillary anterior teeth, then we have to place two posterior microimplants. One you can place in between the maxillary first molar and the maxillary second premolar on either sides, and another microimplant can be placed in between the maxillary incisors. By this you get an effective intrusion. Certain times people have also used the multi-loop edgewise arch wire technique of Kim to correct the anterior open bite. But this is a little bit of a laborious procedure. People used to make it. If you are very good in your wire bending, you could try for one or two cases. But if not, you can do well with the microimplants which are placed and the usage of your retraction coil springs, as the case may require. So this is how MEA view technique of Kim is used to correct the anterior open bite, wherein the maxillary and the mandibular teeth, if they are tipped mesially, they are tipped distally by the MEAW technique of Kim, along with the use of your microimplant and the use of your force. So what could be the take-home message for all? A microimplant, when placed, needs to have primary stability. We do not want it to osseointegrate like we want it in prosthodontic implants. We need primary stability so that it is stable enough for it to resist the forces created. The length, depending upon the type of bone, you're going to alter your length, maxilla, mandible, mid-palatal area, etc. The diameter is important, where you're going to place it in between the teeth. If the interradicular space is less, go for a smaller diameter. If there is enough space, go for a little larger one. So the interradicular space is very important. You want to have more information about this. If you look into my part 1, 2 and the 3 parts, you would understand what I am trying to convey. The biomechanics, absolutely very important. And the type of screws that you are using. As I said, titanium, more so for the microimplants, and the SS screws more so for the IZC and the MBS. And the greatest advantage is you do not have to wait. You can do immediate loading. Another thing that you need to take into consideration would be the bone density, the buccolingual bone depth, and the cortical bone thickness. The soft tissue characteristics, movable mucosa, attached gingiva, tissue thickness, mobility, proximity to the frenum, proximity to the specific anatomical structures like the roots, the nerves, the vessels, the low sinus flow, the nasal cavities. You could correlate all this if you were to look into the part 1, part 2 and part 3, because part 1 and part 2, part 3 and part 4 in total give you the complete picture of temporary anchorage devices in orthodontics. So I thank you all for a patient listening, and please do go into the website and check the links and go through all the parts so that you have a comprehensive understanding of TADS in orthodontics. Thank you all once again.